Okay, so on these disorders, they usually have physical symptoms that have a psychological origin. Um, we'll start with somatization disorder. And with this disorder, it's believed that these are psychological needs that can't be expressed, so they come out in physical ways. So these patients are believed to have repressed anxiety. Often these patients also have anxiety disorder and depression. They often doctor shop, and they have different pain medications and anti-anxiety medications. So drug abuse is a problem. And these patients are normally around 30 years old, so they're pretty young. They have to have, the condition has to be chronic. They have to have 4 pain symptoms in different parts of the body. They have to have 2 GI symptoms. It could be like nausea, vomiting, diarrhea. They need to have at least 1 sexual dysfunction. It could be like irregular menses, erectile or ejaculatory dysfunction. And 1 neuro symptom, and that could be like paralysis, blindness, or deafness. And the symptoms are vague and they're exaggerated as well. So these are the qualifications for the somatization disorder. And these symptoms are very real to the patient. They are not making it up for like to seek drugs or anything like that. Okay, so it's real to the patient. The next one is pain disorder, and this one is the most common. The pain is felt basically like severe enough and prolonged enough that it does cause them social and occupational impairment. So these patients do seek pain medication for the pain, and that's why drug abuse is a problem. They also doctor shop, and they can have multiple prescriptions for multiple different types of pain medication. But usually the pain is brought about by a stressful event and or psychological factors. So even if they come in and the patient does have a real medical condition, but the pain was exacerbated or made worse or brought about by the stressful event, often it could be a pain disorder, not necessarily the medical condition that causes the pain. Okay, so we already said the drug abuse. These patients also often have anxiety disorders and depression. And the primary and secondary gains can perpetuate the disorder. So the primary gain would be the patient gets to avoid doing something they don't want to do anyways because they have the pain. And the secondary gain would be now they get attention that they normally wouldn't get because they have the pain. So these gains can perpetuate the disorder. And the disorder could be acute or chronic, so acute being less than 6 months and chronic being more than 6 months. Okay, so next one here is your hypochondriacs. And they basically have an unrealistic or inaccurate interpretation of physical symptoms or sensations, leading to a preoccupation of fear. Okay, so my roommate in college, he had a stomach ache. He'd always thought he was sick with something. So he had a stomach ache and he thought he had cancer. So that was unrealistic, right? A stomach ache doesn't equal cancer. And a stomach ache doesn't always equal, and it was an inaccurate interpretation, right? A stomach ache is not cancer, but it was real to him, so he was very scared. He was very preoccupied with it and researched it on the computer for hours, right? So these hypochondriacs, they could feel that there is a problem in either a specific organ, like this one, like the stomach, right? Or a bodily function, such as peristalsis, okay? Or even minor physical alterations, such as a bruise or a scratch, can be interpreted as early signs of cancer. And this situation is very real to the patient, so they will become very defensive if you say that it's psychological or it's brought about because of stress, because to them it's very real. Okay, and then also to qualify as a hypochondriac, you must be this way for at least 6 months. And some of these individuals function normally. They can go to work and maybe they just they show these type of symptoms outside of work. So they're not necessarily always occupationally disturbed or affected. Okay, so conversion disorder. This is a deficit in motor or sensory function. It could be, or even seizures and tremors, or it could be both. So this person experiences a very stressful event, and all of a sudden they have a deficit. Either it's sensory or it's motor, or they have seizures or tremors, or it could be both. Okay, and it doesn't have a medical origin. This happened directly after, or it was associated with a very stressful event. And the same thing here. It could be perpetuated by primary or secondary gains. Right now, you have this situation, and you don't have to do something that you don't want to do anyways. And then secondly, you get tension that you wouldn't have gotten normally. Okay, just before I forget, if the patient comes in with, like, let's say like a motor problem, like they have paralysis in a part of their body, or they might have blindness, something like that, their prognosis is actually better than a patient who comes in with seizures or tremors. Okay, so we already discussed that. Okay, it just resolves spontaneously, usually within a week, but these patients, 20 to 25 of them, actually get the symptoms again within a year. The giveaway for doctors is that some of these patients come in, even though with a very seemingly serious condition, right? Like say, like you have a motor deficit in your right hand. That's a big deal. But some of these patients will seem very indifferent to it. So I think it's called labelle indifference, and that's kind of a giveaway for doctors that it could be psychological. But that's not always the case. Some patients come in and they're very dramatic, okay? Very upset about the situation. So they're not always indifferent, but this is a kind of a giveaway. And so it's also called a pseudo-neurological problem because it's psychological. It doesn't have to do with medical reason. Okay, the last one I didn't have room to put up there, but it's body dysmorphic disorder. Okay, so these patients, they exaggerate any flaw in themselves, or sometimes there is no flaw and they believe that there is a defect or deformity with the way they look. These patients are the ones that are constantly at your dermatologist or your plastic surgeon, and these imagined flaws could be, thinning of the hair, or acne, like, oh my god, my face looks horrible, wrinkles that they don't even have wrinkles, or scars, or vascular markings, or, facial swelling, or asymmetry. So any of that, ear, mouth, lips, they could think there's all sorts of things wrong with them, and it's grossly exaggerated. These patients are often associated with delusional thinking, so the psychiatrist might consider also that this patient might have a delusional disorder that is somatically associated with that. These patients also can often have depression or psychotic disorder or anxiety disorders associated with that. And I think that's it. Okay, so on the next slide, I will go over interventions and psychopharmacology for these disorders.